Hello, everyone, and welcome to our seminar tonight. We want to thank you for joining us this evening. My name is Trendalyn Browning, and I am the Reentry and Office Supervisor here at Women on the Rise, Georgia. And as you may know, Women on the Rise is an organization dedicated to empowering formerly incarcerated and justice impacted women. So if you have not done so, please check our website out at womenontherise.ga.org to learn more about our work to educate, heal, and empower not only ourselves, but each other in our communities as we fight for justice and dignity. So tonight, our conversation brings together healthcare providers, movement organizers to expose the denial of menstrual care within the prison systems and also fibroid issues that women that are currently incarcerated and post-incarceration face due to the lack of basic necessity needs while on the inside. So we will have some time later on at the end to take some questions from the audience. So please, if you have any questions, feel free to drop them in the chat and we will answer them at the end or throughout our conversation. So again, welcome. So tonight joining me, we have Melody Rosser, who is our campaign and member supervisor at Women on the Rise. We have Miss Keisha Dickerson, who is our reentry specialist and campaign and health campaign organizer. We have Dr. Alexis Hernandez with Department of Gynecology and Obstetrics with Emory University. And we have Ms. Taylor Nelson from SCOOP, which stands for Stop Criminalization of Our Patients. And she is also with Emory University School of Medicine. So to kick us off, we will be starting with my two colleagues, Ms. Keisha Dickerson, and I will give just a brief bio on both, not too long. So Keisha is the Reentry and Community Health Campaign organizer for Women on the Rise. Keisha spent 15 years in the Georgia Department of Correction Center, and she emerged from that system as a passionate advocate to do this justice reform work based off of her past experience in the Georgia DLC. Keisha is currently pursuing her associates in the medical field so she can continue to further this work and create change. And then we have Miss Melody Rosser, who spent 20 years in the Georgia Department of Correction Center, and she is our community campaign and membership supervisor at Women on the Rise. And after spending her 20 years incarcerated, she transformed her experience into leadership, completing numerous programs while incarcerated and developing several skills that she now uses to shape her work experience. So welcome, Keisha and Melody, to the conversation tonight. So we're going to get started. We're going to ask a few questions and we're going to allow you all to feed off of one another. So if you could go ahead and come off of mute, and then we will get started. So I'm going to throw out a few two questions, give you time to think about them, and then to answer. And if you want to piggyback off of one another, that is perfectly fine. But we're going to start with you, Melody. So Melody, can you share your experience in managing fibroids while incarcerated and some of the challenges that you face while trying to take care of them while you were in the carceral system?
Mhm. Well, Trent, let's say I did not know that I had fibroids
Okay.
until I was released. But the issues, to tell you about the issues leading up to even finding out about
Mhm.
that I had it, it started, I think, around the age of, I went in at 18. I think I started
Mhm.
feeling the pains at 28, the age of
Wow.
28. And I would go to medical. It would be sharp, sharp pains that would kind of paralyze me where I couldn't even move.
Mm.
And, it's an act of Congress to even get a Tylenol, to go down to the officer and ask for a Tylenol. Then once you
Mhm.
put a sick call in, by the time you put it in and by the time you actually get there, you don't have the pain anymore.
Mhm.
And so I continuously put in sick calls, put in sick calls. I think when I turned 32, I
Mm-hmm.
was finally listened to when I went to another prison, which is Alto. And I was
Okay.
finally listened to. And they brought someone in to give me a ultrasound. So and that was constant, all the years going by, putting in sick calls. They're telling me I have gas, they're giving me antacids, they're giving me let's see, antacids, what's the little green pill, the naproxens,
Mm-hmm.
constantly giving me, just band-aids to put on it. And so when I finally had someone to come in from the outside to give me an ultrasound to see, what they could see, I never forget the young lady was in there. I'm laying on the table and she's doing the ultrasound. She has the
Mm-hmm.
screen turned away from me. And she is saying, "Oh my God, oh my God." And I'm like, what is it? What is it?
Right. I know
And
they
she's like,
made like you feel alarmed. Yeah.
I'm trying to turn the screen around. And she's like, I'm just a technician. I can't tell you anything, but the doctor will explain to you what's going on. And I'm like,
Mm-hmm.
just from me and you, what do you see, girl? And she's like, I just can't say I'm only a tech. And so 2 weeks later, it takes 2 weeks for me to get the results back so the doctor
Mm-hmm.
gets the results back. However, God knows how long it took for them to finally call me back. And
Mm-hmm.
she tells me, "Oh, it's just gas, and you may have passed a kidney stone." So this
Even
is at
after
the
all
age,
that the young lady was doing.
yes. So
Mm-hmm.
this is like at the age of 32, and I'm finally released. And when I'm released, this is 2019. I'm
Mm-hmm.
working at the BMW factory in Spartanburg, Georgia. So I
Mm-hmm.
get released, and I can say the weight gain is what made me pay attention to the situation once I was released. Okay, so when you get out, you feel like everything's okay. I can go
Mm-hmm.
to the doctor when I want to, whatever they didn't pay attention to when I'm in there. And you're mainly scared when you're in prison that it could be cancer, the big C word. So a lot of
Okay.
times you don't want to know, what's going on because you don't
Mm-hmm.
want to do more time in prison than you've lived on the street and then die in prison.
Right.
So you're released and you think everything's going to be better. All things are going to be okay. And I got out, I was 172 pounds. I've always worked out in prison. Anybody know me? I go to work, I load trucks in prison, I come in, I walk, I run, I go to bed. I've
Mm-hmm.
always eaten well and taken care of myself. And so I'm released. I'm 172 pounds. Within 6 months, I go all the way up to 190, from 190 to 200. And I remember my niece asked me, "Auntie, are you pregnant?" And I'm like, "No."
Mm-hmm.
But my stomach was so big and so hard, and I'm like, "Oh, I'm just eating good because I'm out. I'm finally out. I'm gaining weight because I can eat what I want." And I'm kind of excited about it. But even when I was smaller in prison, people would always feel my stomach, and they call me Pooh in prison if anyone doesn't know. And they're like, "Pooh, your stomach is so hard. Like, that's not normal." And I'm like, "Yeah, because
Mm-hmm.
I work out." But no, my stomach has a little roundness to it and it's hard.
Mm-hmm.
Um, I have photos to describe what I'm about to describe next. So
Okay.
the photos will come in. But I'm at work at BMW in South Carolina, and I feel an excruciating pain, and a pain that was so bad to the point where I could not even stand back up. So they had to call the ambulance to come and get me from work. Once I get to the hospital in the emergency room, they do a vaginal ultrasound, and they're like, "You have extremely large fibroids." And I'm like, "What?" And they're
Wow.
like to the point of 14 centimeters. I'm like, 14 centimeters? Well, how many inches is that? I'm like, seven. So I'm
Mhm.
thinking, like, how many inches is this? What's going on? They're like, "You have to have immediate surgery."
Wow.
And I have no time to call family. I have no time to do anything. My boyfriend at the time, he was working with me. He was there, but when they took out what they took out, I
So
was so
these what's they're showing is what was taken out of you. Those three.
yes.
Wow.
And so I always tell people these are my children. Because of this situation, I cannot have children, and
Mm-hmm.
so this is what they took out of me. So this is
Mm-hmm.
probably what this young lady was this tech, this ultrasound tech was seeing in
Mm-hmm.
prison, and they did not inform me that this was going on. Um, and they did not feel the need because the same thing that the doctor saw on the outside from a vaginal ultrasound, she was doing the same thing in prison, a vaginal ultrasound. I'm pretty
Mm-hmm.
sure, this is what they saw. And I don't know if it's because the prison didn't want to pay for it, because the prison didn't want to foot the bill for me, getting back on my feet.
Mm-hmm.
I'm not sure. I can't even answer for the prison as to why they did not go ahead and get me the surgery or some another type of situation. I heard now that they can cut off the blood supply to the fibroids. Um,
Mm-hmm.
they just, when I got out, I was able to, due to the emergency, get a myectomy, but the prison did not
Okay.
even at any time feel that there was a need to do that for me. And I just suffered in pain. And I'm so used to suffering in pain. Like, you have this pain, you try to ignore it and keep pushing on, hoping that later
Mm-hmm.
on it'll go away. Just this Friday, I was having a problem. And, I called my boss and I was like, man, I'm kind of scared because I feel the same pains. I feel the same
Mm-hmm.
pains that I was feeling then. And if she had not have gotten onto me and told me, go ahead and go to the doctor this Tuesday just passed, I wouldn't have,
Mm-hmm.
have gone because I was telling her, well, maybe if it goes away by 12 o'clock, I'll call my
Mm-hmm.
doctor if it doesn't, because I'm so used to functioning in pain. I'm so used to
Mm-hmm.
trying to survive and and grow with that's what I've been conditioned to do in prison. But when
So
I
I
went
was
to the
getting ready to
doctor,
ask.
go ahead.
So you feel like that, like, of course, they didn't support you or they didn't even understand what you were going through. So you feel like that kind of shaped the way that you think now when it comes to you taking care of, having those pains and those issues. Like, oh, because I remember you saying the other week at work, like, I don't even take Tylenol if I don't have to. Like, you have conditioned yourself to just deal with it and suffer through it. Like you were just saying, had you not called um, the ED on Friday.
Yeah, I would have thought just keep
Mm-hmm.
going through it because my mind is
Mm-hmm.
I've suffered through worse. So, and when I went
Mm-hmm.
to the after my surgery, after my as I call them, my three kids were removed,
Mm-hmm.
I had ultrasounds after that, and they would tell me that we left a couple in because they were the size of a pea. But now, going to the doctor on Tuesday, I found out that those size of a pea are the size of a 3-month fetus now. And so, yeah, so
Wow.
and they've grown since then. This surgery was in 2022, and so now they've grown since then. Um, but yeah, and they grew just seemed like overnight. I saw myself 2 weeks ago. I was on a cruise. My stomach was so flat. I was looking so fine.
Mm-hmm.
But I woke up Friday. I was like, wait a minute, something's going on.
Wow.
So
Yeah.
yeah, just suffering in silence and
Mm-hmm.
trying to make sure that I tell myself that you deserve to change that. But yeah,
Mm-hmm.
that's
Yeah.
all.
Well, thank you. Thank you for sharing. So, Miss
Mhm.
Keisha, can you share your experience on managing fibroids while incarcerated and some of the challenges that you face trying to get care? You're muted. If you can unmute your speaker.
Just to piggyback
Mm-hmm.
off of Melody, I
Mm-hmm.
suffered the same issues, going to medical, having to put in sick calls after sick calls. A lot of times when you do go up there, you're faced with appointments getting canceled. They are telling you that, it could be gas. But I also suffered what they were trying to tell me was anemia. So that was the cause of a lot of my issues that they felt was the reason why I was in a lot of the pain as well, why I kept having a lot of pelvic pain. But however, I had to start writing grievances on them to start getting them to actually, for me to be seen by certain specialists. So I was sent out to outside doctors outside of just the surrounding area and having the
Mm-hmm.
ultrasounds done outside of there. That's where they were letting me know that I did have fibroids and that they had grown from just the size of a pea to the size of a plum. So she was telling me that, that they will continue to keep growing. So my only option was to either deal with the pain or to get a hysterectomy, and so, most people don't want to just deal with the pain,
Mm-hmm.
especially when it's excruciating. And I have a high
Mm-hmm.
tolerance, but it's only so much that a person can continuously to keep taking. So,
Right.
there were 4 different types of hysterectomies, and I didn't know that at the time. I only thought that either you had the vaginal or the abdominal. So
Mm-hmm.
they were letting me know that, she says, yeah, we have new technology now. You could get the abdominal, the vaginal, the laparoscopic, and the robotic. So when she
Mm-hmm.
said that, I said, robotic?
Mm-hmm.
Where did this come into place? She says,
Mm-hmm.
yes, it's less invasive and you also have less downtime. So I was all for that. So I said, well, let's do the robotic. So I was one of the first people to ever do the robotic surgery. However, it's 4 hours long and you're turned upside down. And it was pretty neat. One of the officers were inside with me where I was able to have the robotic surgery done, but I only had I I was only in the hospital only just for that day. I was able to leave, right after less than 24 hours. And within a week's time, I'm up and walking and able to, go on about my business. So that was the only great thing about it. However, for so many of the other ladies that are in there, for those who don't utilize their voice to advocate, to, speak out for themselves, because so many of them think that they're going to get into trouble for saying something
Mm-hmm.
about
Mm-hmm.
their health, but at the end of the day, you have to just let them know that what else do you have to lose, besides your health, you know.
Mm.
So that's one of the things that you do face in there because of the fact that they don't look at you as human beings anymore. They just start looking at you as numbers. And that's what you face,
Wow.
challenge that you face in there.
Wow. And I know that a part of like in your bio, it talks about that's what led you into this work here at Women on the Rise, right? The advocacy part. So what does advocating for yourself look like to a system that don't really understand or support your needs? I don't even want to say don't understand, but that don't support your needs. Like how I heard you say you wrote grievances and different things like that. Can you explain the grievance for those who may not really know? Some people may know, but just for those who don't.
So for the grievance process,
Mhm.
you have to basically, it's a slip of which you have to state the cause of action that did not happen for you. You have to
Mhm.
write down the time, the date of the incident that occurred or that did not occur. You have to
Mhm.
put what was said, what was not said, what was done, who did what, when, where, and how. And you have
Mhm.
to make sure that you give accountability of the accounts of everything that transpired. And you have to make
Mhm.
sure that you truly dot your I's and cross your T's on every single thing that was done on that specific day. And then you have to get a counselor, and it could be any counselor. It doesn't necessarily have to be your own counselor. You have to get a counselor
Okay.
to sign the grievance for you, and they give you a receipt for it after which. And that is what you have to use in order for you to get them to, start listening to what it is that you have to say about your situation.
Oh, wow. Okay. Well, thank you. Thank you both for sharing. And don't forget, y'all, we will be taking questions. As we prepare to transition, we're going to bring Dr. Alexis Henderson, I'm sorry, Dr. Alexis Henderson on, and we'll be having some more discussion, and she will be talking to us about from her professional experience. So you are muted, Doctor. Welcome,
Hi,
welcome.
thank
How are
you
you?
for having me. Good. Thank you for having
Good.
me.
Of
Um,
course.
yeah, so I just wanted to start by saying, thank you so much, Melody and Keisha, for sharing your stories. I think you guys set me up so beautifully because a lot of what you guys discuss, I'm going to delve into a little bit in these slides. But the thing that just really stands out to me as a doctor is hearing you guys talk about your stories. I hear how much time you had to spend learning these things on your own so that you can advocate for yourself, because I will say, talking to like the average patient, they don't know as much as you two clearly know. And I think it is so wonderful that you know this, but I also think that is a product of you having to know it so that you can advocate for yourself. And that's really, really powerful. So I just wanted to take some time to just discuss fibroids, just briefly, how we diagnose them, how we manage them, so that other folks can have the tools in their toolbox to advocate for themselves as well, and just know about this really important public health issue that faces women. So starting off from the very basics, what are fibroids? So the uterus, which you can see here, You can see the vagina leads to the cervix, which leads to the uterus. The uterus is made up of three different layers. You have that inner layer, which we call the endometrium. That's what you shed during your periods or what grows to house a baby. And then you have the muscular layer, and the uterus is a large muscle, and that's because contractions are those muscles contracting down to push the baby out. Also, contractions occur during menstruation to push the menstrual blood out. And then you have this outer layer called the serosa, which is just kind of like the gift wrapping on the gift of the uterus. Fibroids are benign. Benign means non-cancerous growths of the muscular layer specifically. So the cells in that muscular layer, for some reason or another, grow out of proportion and they turn into these large masses. You may hear them called leiomyomas or myomas. These are just fancy words that doctors use for fibroids. All right, next slide. And who's most likely to have fibroids? So fibroids are most common in women who are reproductively aged. So usually we diagnose them around the age of 30 to 40, but they can really occur at any age. They occur more often in Black women, and we don't really understand why. We don't generally think that being Black in itself is a risk factor for fibroids, but maybe racism in this country and the experience of being Black in this country is a risk factor for fibroids, because we know that fibroids are related to hormonal changes in our body, and hormonal changes can be impacted by levels of stress. They occur typically at a younger age, and they grow more quickly in Black women as well. So it's important to recognize that fibroids disproportionately affect Black women and in a very different way than they may affect other women. And there's some research that's kind of pointing towards the fact that fibroids may run in families, but this is kind of not fully elucidated just yet. And next slide. What causes fibroids? So again, we're not 100% sure, but we know that fibroids feed off of estrogen. So estrogen is a female hormone that we produce in our ovaries, and we produce it cyclically from the time we start having our periods to the time that we stop having our periods, so till menopause. And estrogen is really what causes fibroids to grow. So I think something that's really, really important to both Melody and Keisha's stories is that fibroids will continue to grow as long as your ovaries are still producing estrogen. So we don't typically see them shrink or stay the same size. So I know Melody's story, she talked about how she had pea-sized fibroids. Any good gynecologist would really warn a woman that those fibroids are going to grow, because as long as you're producing estrogen, they are going to grow. And so really, when we are removing fibroids surgically, we try to remove all fibroids regardless of their size. Obesity can increase the growth and the risk of fibroids because fat tissue actually produces estrogen. Not getting pregnant can also increase the risk of fibroids, because when you're pregnant, your body is producing less estrogen, so it's almost protective against that. And then high blood pressures also increase the risk of fibroids because you produce more estrogen when you have high blood pressure. So these are things that we don't necessarily think about as being related to our reproductive health, but are very much related to reproductive health. Next slide. And so what are the symptoms of fibroids? So the most common symptom, and the reason that we're talking about fibroids today is because they cause really irregular bleeding. They typically cause really heavy periods, prolonged periods, and very painful periods. I've seen patients who have extremely low blood cell counts because they bleed so much with their fibroids. And so it can cause really severe anemia to the point where patients are requiring blood transfusions or even having life-threatening anemia. They can cause severe pelvic pain, as you can see in these pictures, especially this one on the top. When they grow this big, like maybe the size of Melody's fibroid in this picture, they press on nearby structures, including your nerves, your blood vessels, your bowels, your bladder, and that is really uncomfortable and causes a lot of pain. They cause issues with urination and issues with bowel function. We frequently see that patients have really terrible constipation when they have fibroids because it's just pressing so much on their bowels. And I think something that I always took for granted is how regular bowel movements are so important to our quality of life, constipation is really, really debilitating for patients. And so I know that it may not sound like a big deal, but some folks who have really horrible constipation, they really struggle with those symptoms. And then fibroids can cause infertility, especially the larger they get. If a pregnant patient has fibroids, she's at increased risk for a lot of pregnancy complications. It takes up space in her uterus, and so there's less space for her baby to grow, and so babies can grow smaller. There's higher risk of going into preterm delivery and preterm labor, and then those babies have higher risks of complications as well. And I think this is really important to kind of relate to the fact that Black women are experiencing maternal mortality and morbidity at higher rates. And there are a lot of different reasons for that. But maybe some of the reasons are because we're not adequately treating women when they're not pregnant, before they get pregnant, for some issues like fibroids. And then you can see in this lower picture, this is a fibroid that's closer to the cavity, which is where the baby would grow. And that can really lead to things like infertility. Next slide. So how do we treat fibroids? The mainstay of fibroid treatment is hormonal medications, because as I mentioned, fibroids grow with estrogen production. And so you can see on this graph on the right-hand side of the slide that as we go throughout our cycle, we naturally produce higher and lower amounts of estrogen throughout our cycle. What hormonal medication like birth control does is it kind of pauses the cycle in one point of time so that our estrogen levels are staying steady but low rather than going up and down throughout our cycle. And that keeps the fibroids from growing, and it can treat some of the symptoms of fibroids like heavy menstrual bleeding or pain. Hormonal medication is never going to make fibroids go away altogether, but it can control their growth so that once a woman reaches menopause and she's no longer producing estrogen, then they may shrink on their own at that point and not cause any troubles. But hormonal medication is only as good as you're taking it. When you stop taking the hormonal medication, the fibroids will start growing again. Your symptoms will start to come back. I think it's really important to point out that we are not giving women access to these hormonal medications while they're incarcerated. And so we're literally putting them into a situation where their fibroids are growing and growing and growing. And they're getting to a point where they're so big that they're causing more trouble than they may have been if we treated them earlier.
Well, thanks, Alex, for all of that information. We're going to come back. We're going to transition to Taylor right now. And I know that you probably have more slides to go through, but I think the framework and the groundwork that you laid will be a great time to transition and ask Taylor some questions, especially since you were talking about incarcerated people not getting the medical treatment that they need. So, hello, Taylor, if you would unmute yourself. And because you are with Scoop, and Scoop is an organization that works with directly impacted people to try to get them the medical care that they need. How does Scoop address the healthcare needs of people impacted by the incarcerated system?
Yeah, so for those that don't know what SCOOP is, SCOOP stands
Mhm.
for Stop Criminalization of Our Patients, and it's really
Mhm.
a collective of clinical and public health professionals that are really dedicated to challenging the harms of the criminal legal system. And
Mhm.
we operate in like three pillars for the most part, and the first one really centers political education. So the goal is not just to improve the conditions of the jail or prison environment, but to actually think about how we need to transform as an American society to think about how we view health and safety. And contrary to what a lot of people think, prisons and jails are actually not contributing to public safety. And if anything, they actually perpetuate the very harms of why so many people across this country end up incarcerated. So Scoop really wants to do a better job at collaborating, partnering with other people in our community to educate not only health professionals, but more people across the state of Georgia to think about how we need to do better work when it comes to the criminal legal system and actually acknowledge incarceration as a preventable condition. The second pillar is really about clinical care. So our founder and director, Dr. Mark Spencer, he runs a transition clinic for formerly incarcerated individuals to think about how they need to be treated with more respect, more dignity, more compassion. And there's this concept called dual loyalty, which is basically the way providers navigate both providing proper care to those who have been incarcerated, but still adhering to clinical responsibilities that they have. So he has done a really amazing job at training Scoop to make sure that we're building better trust with providers and patients and those who have been impacted by the legal system. And then the final pillar is really just about community organizing. And that goes back to what I was saying earlier of just there's so many non-clinical components of health, like access to healthcare navigation, access to food and shelter. And all these things really stem from decarceration and public health and how we're viewing the holistic idea of health. And Scoop really wants to work with healthcare professionals, lawyers, policymakers, community organizations like yourself to really make sure we're acknowledging these pathways into incarceration and better support these communities.
Oh, thank you. Wow, that's amazing. Okay. So tell me this, why is clinical care alone unable to promote true health and well-being in a carceral setting?
Yeah, we really need to think about how prisons and jails, at its very core, really prioritize punishment over healing. And if you think about the very way that clinical care is provided and how it operates, it really contradicts the very public health values, human rights, and human dignity. Even if you look at the physical environment of incarcerated settings, you're locked in cells, there's bars, there's a lot of surveillance, there's a lot of restriction, and none of those factors are actually conducive to health and well-being. And we need to think about how these very physical environments actually shape and cancel out the effects of clinical care. And you could have the best clinical care provided to you in the world, but if you're in an environment that isn't actually bettering your health, making you feel safe, making you feel seen and validated, it's not actually, again, bettering those conditions of health. I actually did some research recently on mental health care specifically within carceral settings. And there were over 200 legal violations where laws were actually explicitly broken in how clinical care was provided. And this goes to show that if we continue to rely solely on clinical care without considering the holistic and broader determinants of health that are impacting these women, we're not actually getting to the root of why so many people end up incarcerated in the first place. But even if we just look at women, women of color are such an important part of our community, and we need to take that into account.
Thank you. So with that, what you were just saying, so we know that initially the carceral system was built for men. So how is it that a carceral system that's built for men create health and safety problems for women?
Yeah. Similar to what I was saying is like if you look at the very environment that carceral settings are and the way they're set up, they really don't account for the gendered, the racial, the cultural components and pathways that lead someone to be incarcerated. And a lot of those, particularly women of color, don't actually need to be incarcerated in the first place. And part of that goes to stigma and gendered pathways into incarceration. The way women get pipelined into the prison system, those are factors that are not actually considered and set up within the prison or jail system. They're put in higher level security than is actually necessary. Their medical needs and conditions are diminished, overlooked, and devalued. They're subject to sexualization, objectification, which many have experienced prior to incarceration or in adverse childhood experiences, which the prisons are just simply not equipped to deal with. There's also just the regular idea of gendered specific care, kind of like what you guys have been talking about in terms of fibroids. A lot of these conditions, even if you provide the proper clinical care, the way both carceral staff and clinicians are trained in facility are not actually looking at why women are dismissed and overlooked so often that their voices continue to be devalued. We're not actually taking their word for what it is and considering their needs above carceral punishment and punitive measures. And then, as I said earlier, just community destabilization of these are such important members of our community, not just within the prison, but when they are released. And if we're neglecting their health needs while incarcerated and thinking about this male phenomenon of how prisons were set up, we're really perpetuating the cycle of incarceration and not better supporting the health well-being of not just those who are currently incarcerated, but future generations.
Thank you so much, Taylor, for the way that you broke that down and sharing information on Scoop, the organization that you are with. So now we're going to transition to Q&A because there have been questions dropped in the chat. And so we're going to bring all of the participants or the panelists back on. So and just ask some questions. So the first question, I guess, will be for you, Dr. Alexis, and the question is it true if you have a very small uterus, you cannot get fibroids?
No, unfortunately, that is not true. So anyone with a uterus, doesn't matter how big or small it is at risk of getting fibroids because no matter how big or small your uterus is, you still have those three layers, including the muscular layer that can grow fibroids.
Okay. And there's another one since you're talking. Is there anything that you can do to control fibroids other than a hysterectomy?
Yeah, I actually had this on one of my slides that I didn't end up getting to. I'm not sure if we're able to pull them back up, but
Okay.
there are definitely other options. So we talked a little bit about medical management. The next one would be surgical management. And as Keisha beautifully stated, so if you go to the next slide, I think it'll be there. Perfect. So, as Keisha really beautifully stated, there are multiple different types of surgeries that we can do these days. And so the first one that you see up here is called a hysteroscopic surgery. This is where we don't have to make any incisions in your body at all because we just go in through the cervix and we remove the fibroids from inside the uterus. So importantly, these fibroids have to be accessible from inside the uterus, which not all fibroids are. Then the next one you can see here is laparoscopic surgery. That's where we make small incisions. We go in with a camera and some tools and we're able to remove the fibroids. This is a minimally invasive approach. And so it's nice if we catch the fibroids early enough so that they're small enough for these types of surgeries. So another huge harm that we're doing by not diagnosing and treating fibroids early is that we're allowing them to get to a stage where they can only have an open surgery or a large incision that's much harder to recover from. And the last one is my favorite, like Keisha mentioned, robotic surgery. So you can see the surgeon down here is actually sitting at the console and controlling the arms of the robot. And then the robot's tools are actually inside the patient's body performing the surgery. This is the most minimally invasive approach, the least amount of blood loss, the least amount of pain, and the easiest to recover from. And we can only do this with fibroids that are of a certain size. So we can remove the fibroids, that's called myomectomy, but it's important to recognize that whenever we remove fibroids, you still have your uterus and you're still at risk of having additional fibroids in the future. So they can come back. There might be smaller ones we didn't remove that grew. And then there is the hysterectomy. That's the only treatment that's permanent. So we take the uterus out altogether, and all of these, you can do it laparoscopic, robotic, or open. And that's the only way that we can confirm that the fibroids will never come back because you no longer have a uterus. And then, as Keisha mentioned, we can actually cut off the blood supply to the fibroids, and that causes them to shrink. But there's only certain fibroids that we can do that for. So you have to get sort of specialized care, and not everyone offers that. It's a little bit harder to find that option. So different options.
All right, thank you. So Keisha, so after your surgical procedure, were you able to follow up with your doctors, and did you receive barriers from the prison once you were going back to try to get these appointments once you went back?
Believe it or not, I was able to follow up with my doctors, and you'd be amazed at what grievances can do. So, no, I didn't have any barriers. The grievances, like I said, they worked wonders. I became known as the pen to the paper person. So yeah. So
Okay.
yeah, I had no problems ever receiving any more medical treatment when it came to my health. So because they knew that if any issues pursued pertaining to me, I would put the pen to the paper.
All right, pen to paper. All right then, ma'am. And Miss Melody, did fibroids cause excessive bleeding while you were incarcerated? And if so, how did you manage that with the limited amount of supplies that you were given?
Well, it made my menstrual period really odd for a good while. After the age of 28, it was 2 days heavy I'm talking about heavy, where you're not even
Mhm.
walking out of the room. And then the rest of the 4 or 5 days, it was just spotting. I've been like
Mhm.
that until I was released from prison. But the constipation was constant. I'm always constipated. I don't do, and still to this day, I don't have regular bowel movements after every time I eat like other people do. In prison, it was once a week, something like that. So the constipation was just, when she said that, I said, you know what, I forgot all about the constipation. I forgot to say that because
Mhm.
I've had that problem for a long time. But that's how the period was: 2 heavy days, and then after that, just spotting.
Okay. Were you able to get the supplies like you needed during those 2 heavy days?
I'm gonna tell you about supply call, and that's what we call prison. When you get your toilet tissue and your feminine products, we call it
Mm-hmm.
supply call. Um, the officer or the sergeant would kick a box into the door, a box of tampons, and it may have had maybe 100 for 86 women, and it's a free for all. The biggest and the strongest survive. Will be able, whoever gets it first, and know that they're out there, and you can grab as many as you can grab. And that's how we had to survive. And the ones on the store, if you didn't make, your family did not send you money, you could not buy the tampon and feminine products on the store. So I was someone who didn't have any parents or anyone out there sending me money. Um, Once I
Mm-hmm.
started to work in, well, we call them details. Well, once I started to get details where I worked with the staff doing their hair, I was able to use their supplies. But before I got into staff cosmetology, it was a free for all. And I hope I was there when they came and kicked that big box in. So I had to fight to get them.
Mm-hmm.
But yeah, that's how it
Wow.
was.
Wow. That's
Or wear
horrible.
tissue, wear
Or
tissue,
tissue.
or, yeah.
Mhm. So, Taylor, when you are out advocating or educating people about, not criminalizing people or patients, what kind of feedback do you all typically get around advocating for incarcerated or formerly incarcerated people?
So those that actually take the curriculum that Scoop does offered, I would say overall it's a very positive feedback. We're gathered in a room to really acknowledge within our own lanes how we can better respect and dignify those who have been incarcerated. And I think the biggest challenge is really just making that a systematically understood thing. I think as a clinician, you have a responsibility to uphold both the institutional and infrastructural needs of what you're supposed to do as a clinician, but acknowledging that these women come from histories and traumas and unique pathways into incarceration. I think the feedback would come from those who may not necessarily either understand the criminal legal system and how we're supposed to cater to these patients, but just how can we make sure that is an ingrained and universally understood approach to clinical care.
Thank you. So to piggyback off of that, for you, Dr. Hernandez, are there any plans to educate healthcare providers within the penal system of the urgency to identify fibroids and to treat those individuals?
That is such a great question. And I love the word urgency because I truly do think that there should be urgency in identifying and treating this. I would love to be involved in something like that. I don't know how to get involved in something like that. So if anyone has any ideas or has like the connections to make that happen, I am so happy to help. I think that is such a great idea. Unfortunately, I do not have any plans or the know-how to do that just yet, but I'm so happy to be involved in something like that.
Yeah, that sounds like a call to action for me, something we need to be working on. One more question for you, Dr. Alexis. How can a woman reduce the risk of getting fibroids? Do you believe that diet is a factor that contributes to it, or any other ways that a person can possibly reduce their risk?
Yeah, absolutely. Great question. I absolutely believe diet is a factor. We talked about how high blood pressure and obesity are risk factors for fibroids. So, diet obviously plays a really big role there. Foods that are high in saturated fats, foods that are ultra processed are definitely playing a role in fibroids and fibroid growth. And so, I think that kind of ties back to Taylor and her discussion of how the environment that we live in impacts our health so much. You know, women who live in food deserts and don't have access to healthy foods that are affordable are the ones who are typically bearing the brunt of, you know, fibroid burdens. And so diet absolutely plays a role. If you're able to decrease the amount of fat and salt in your diet, I think that could play a huge role in helping prevent fibroids and fibroid growth. There's also a lot of studies right now about vitamin D in fibroids. This is not something that we necessarily like recommend vitamin D supplements for people who have fibroids, but I think that is an interesting area of investigation. Almost everyone I come across in my clinic is vitamin D deficient. So that is something that, you know, could be interesting to look into further. But I would say just generally like a healthy diet is going to be the biggest thing that you can do for yourself.
Okay, thank you. So Melody and Keisha, do you know of a way of how we can get more menstrual items like sanitary pads into the carceral system, into jails, prisons, so that women can have them?
I'll go first. I think it was 6 months ago, someone called from prison and said, "Hey, we don't have our menstrual products." I got on the phone right then and I text Mr. Holt. Mr. Holt, I think he's something over DOC. I met him at the Capitol. And I texted him. It was 6 o'clock. He texted back 8 o'clock at night. And he said, "Well, you know, I just called down to the prison and they said that they have menstrual products." I said, "Well, they can always say that they have it, but are they issuing it?" You know, because I remember going with a sergeant to the warehouse. There's pads and tampons in the warehouse. So why are you only kicking in one box of 105 to 86 women? You know, so just you can call them and they will tell, "Oh yeah, everything's fine. Everything's fine," when they call the higher ups. But how can we get it actually distribute to the ladies? I guess we have to continue to make noise, and then be able to make relationships with inside the prison of those who are in authority over those supplies. I think that's our next thing that we have to do, because we have the higher ups, we see them all the time out here, but it's a whole different ball game. It's a whole different world inside.
Okay.
So yeah,
I concur.
Okay. That's all you concur. All right. So for all of you ladies, this will be our last question. What can communities and organizations do to advocate for better health access? We'll start with you, Taylor.
I would say the first and most important thing, whether you're a clinician or you're just a regular community member, is to listen. A lot of these women are deprived from the platform and the space to actually share their stories transparently and honestly, and we need to stop overlooking these stories and use them as important experiences in co-creating policies and programs and next steps and these call to actions that we're discussing. It really just comes down to better supporting these women and making sure that they are heard and seen in every space.
All right. Keisha?
I say advocate for independent medical oversight of the correctional facilities to ensure that the care meets the community standards, and train the correctional staff and the medical providers on trauma-informed approaches by reducing the bias against the incarcerated patients.
Dr. Alexis?
Yeah, I would piggyback off of what Taylor said and say share your stories. You know, I'm so grateful that Keisha and Melody were sharing their stories with us today, because we, you know, get to use that information to help us advocate for our own selves in the future. And then also, I think every woman, whether they're incarcerated or not incarcerated, should be seeing a gynecologist every year. If you have a complaint, if you don't have a complaint, you should be doing a routine annual exam with your gynecologist. So making that standard of care for incarcerated women.
And Melody?
I say for everyone that's on this call, and if you know someone that any woman that is plagued with fibroids, please have them to contact Women on the Rise, or either go onto our website, Women on the Rise GA. Get with us. Let's share our stories. Let's go down to our legislators and make sure that we share our stories with them so we can get laws changed for those who are in the prison system, who that we left behind, that are still struggling with these issues, because you shouldn't struggle with this alone. And I know I struggled with this alone for a long time, but if we can change laws and policies around this issue, we can get some things changed for everybody.
Well, thank you, ladies. Thank you, Taylor, Keisha, Dr. Alexis, Melody, for sharing your insights on this failure that continues to plague women in the carceral system. Thank you for everyone that took time out of their evening to join us and to listen to what was discussed. Make sure that you sign up for updates from Women on the Rise at www.womenontherisega.org so that you too can get involved in this campaign that we have going on, as well as just to stay connected with us. And so we can continue to push this forward. We appreciate you all. We want to give you back 8 minutes of your evening. So again, thank you all for joining and look forward to seeing you at our next webinar.